the Netherlands. Can you see the questions?
Yeah. Mm-hmm. Oh, the question is about why are public health authorities de-emphasizing or not even mentioning home treatment? Like I mentioned, those 4 pillars, and it's simply not mentioned in any way. I think part of it is just science. We want to have that standard number 1. We want to have proven efficacy and safety, which is a chronic disease model. For the next diabetes drug, we want proven efficacy and safety. And we're not used to pandemic model. Pandemic model means it's an emergency. This is like war. And you can think about a soldier who is shooting bullets, and the next box of bullets, the soldier's not going to ask, listen, has this been tested in a large randomized trial with confirmatory results? And they say, listen, do you think the bullet's going to shoot? Yeah, give me the bullet. And so a lot of this has to do with taking a much more of an emergency approach, using drugs that are safe and have a reasonable probability of effectiveness is appropriate in an emergency. Many public health officials haven't gotten in their mind that this is an emergency, and we're seeing the mortality, the body count continue to rise. And I think this fall, which is obvious now, our numbers are going to blow through the roof worldwide. I think there will be now, I showed you the take-home packages in South America and India, what have you. You're going to see that people are going to come into line. My regret is that it's too late. We should have gotten on this right away. I didn't know what to do in March or April, but I did in May. And I tell you, from May forward, I think we should have gotten after it. Brian, you probably started.
Yeah, we started in March. And again, you know, my background in emergency medical care, you know, we deal with the situation on hand. And I think that that's the difference in philosophy versus academic institutions where, you know, we're constantly taught in med school and in residency programs and academic institutions, you know, what's your clinical data, you know, what's your approach to, you know, what studies and which criteria are you using for this treatment and that treatment. And, you know, we're so geared on protocols and evidence-based medicine and all of those things. That's what we're taught. But you don't realize, you know, when you get a pandemic like this, there is no information available. You have to basically try to figure it out. And you know, if something appears to be working, well, then you're going to give that a shot. We gave it a shot. We started seeing some results, and we continued with it. It was an adjustment. Like I said, it's always been about a reevaluation process. You know, we're going to see what does this look like. You know, how do they tolerate the medication? That was another issue. You know, we were starting to see the GI upsets with the hydroxychloroquine. We didn't know if it was the hydroxychloroquine or the zinc. So we would stop one and try the other and try to figure out, okay, well, which one was really causing the GI upset? And then when we realized, you know, yes, it's just the hydroxychloroquine, we told the patients, if you can handle it, continue with it, and we'll see. You know, give it another 2-3 days, and most of those times the symptoms would improve. But it's a different approach when you look at the emergency medicine side versus the academic side. And I think that's why you have this big disconnect between, you know, institutions and people, you know, accepting what we've done as far as our work, and people who won't accept what we've done as our work. You know, I always go back to who's the one in front of the patients. You know, that's who you want to talk to. You want to talk to the doctors who are seeing the patients. They're going to be the ones to tell you, you know. I can tell you, you know, this patient's going to do well, this patient's not going to do well now, just by looking at them, you know. And so we want to be a little bit more aggressive here. We want to be, you know, everything's going to be fine on this side. That's the approach that I think we need to continuously reevaluate in any pandemic. You know, is understand that this is not your typical academic medicine. It's not, you know, clinical trials and you know, evidence-based research and what you can pull off of up to date, and you know, what's the latest guidelines, and that's not how you practice medicine during this time.
If I could comment, medicine is both an art and a science. And in this pandemic, we've really focused on the science in randomized trials and new drug development, what have you. And the body count, the hospitalization and the mortality has been through the roof. And what Dr. Tyson and I are saying is we also have to focus on the art of clinical judgment, careful observation, being able to quickly adapt to new concepts, to reevaluate patients. And what we put forward is we should do something in terms of reducing viral replication, something to treat cytokine storm, and something to treat microthrombosis. Those three principles. It looks like it's working. We don't have much time left to really adapt to a worldwide model of home treatment before mortalities start to escalate through the roof. I think there's so many lives that can be saved. That's the reason why we are putting every bit of our professional and personal effort in this message of early home treatment for COVID-19.